All right. Hi, good afternoon, everyone. My name is None Ramonati. I wish to welcome you to this session today. It's Monday, the 13th of June. Yeah, I welcome everybody. This ECHO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. We've got participants from 5 countries today, so I wish to welcome you all. There will be a chat session open after the presentation, and our presenter is Dr. Siyanda Mahlasela. He'll be talking to us about nutrition today. So without further ado, I wish to welcome Dr. Mahlasela to start with his presentation. So, Siya, good luck. Thank you.
Okay. Good evening. Let's get this up and going. Good evening. I'm Siyanda Mahlasela. I'm a fellow based at Bara with Prof. Ali. My supervisor for this topic is Dr. Ramonati. The topic is quite a broad one, nutrition feeding, including refeeding syndrome, but we've tried to summarize it in a pragmatic and practical manner, and hopefully, it will whet your appetite about nutritional disorders and stimulate some discussion around them, as well as research in this area. This is an outline of the presentation. We'll cover an overview of nutrition, touching on the public health aspects. And then we'll see why it's important that clinicians know about nutritional therapy, touching on a report from the UK titled A Mixed Bag. And then we'll go through nutritional assessment, access, and feeding, and how you would then monitor these patients, and close off with some complications, including refeeding syndrome. And hopefully by the end, all of your questions will have been answered. So everyone in the world is affected by nutritional disorders in one way or another. There's about 155 million children that are affected by child stunting, and about 52 million are affected by child wasting, and that really relates to malnutrition related disorders. Amongst the adult population, about 2 billion suffer from diseases related to being overweight or obese. And of course, we know those diseases are related to metabolic syndrome, diabetes, and various cancers. Not only those disorders, but also there's about 2 billion people in the world that are affected by micronutrient deficiencies, so including iron, folic, vitamin A, etc. So if one looks at nutritional disorders from one spectrum to the other, one can see that in the one end, there would be malnutrition, and in the other, there would be overnutrition, that's obesity or being overweight. And each one puts the host or the patient at a particular risk. For instance, patients with malnutrition are more susceptible to infections, such as what we see commonly in our setting would be TB. And I've mentioned for patients that are obese, the metabolic syndromes. But closer to home or closer to GIT-related disorders, one may consider NAFLD as well as gastroesophageal reflux disease. This is a nice view, but is rather simplistic, and an updated model is one that not only looks at the ends of the spectrum, but also at the various gray areas in between. So for instance, patients with sarcopenia or frailty and patients with micronutrient abnormalities, those patients also tend to do poorly in the hospital setting or in the ICU setting. And malnutrition has been then further categorized into disease related with inflammation, disease related without inflammation, as well as malnutrition without disease. If you look at this picture, you'll see that South Africa is still considered a high risk of malnutrition. And in our population, just about 30% of children under the age of 5 suffer from malnutrition, while about 13% of children suffer from obesity. It's difficult to get the prevalence of malnutrition amongst the population of adults, but amongst the hospitalized cohort, the prevalence was reported to be as high as 45%. Not only that, but in the wake of the COVID pandemic, this has exacerbated the situation. For the last 30 years, we've seen a steady decline in the number of children under 5 years suffering from malnutrition. But in the wake of the COVID pandemic, for the first time, we saw a reversal in this trend. So COVID has had quite an impact in malnutrition as well. So if one looks at the malnutrition related and malnutrition, one may think about food security, and that's where most of the public health initiatives are targeted. Most of the time, what we are interested in is, the process. So that is digestion as well as absorption. But for the vast majority of our patients, they're affected by the combination of the two. So they suffer from access to food, and they may as well have a disease process that impairs digestion as well as absorption. And so one may ask, why does it matter? And the reason that it matters is patients that suffer from nutritional disorders have an increased hospital stay. This is because they tend to have higher rates of complication in hospital, like nosocomial sepsis. Even if they undergo surgical procedures, they tend to have a higher complication rate, and they have increased ICU stays compared to patients that don't have any nutritional disease. A new term has been introduced recently to try and move away from saying patients are malnourished, because it's not only patients that are malnourished that would be at risk. So people talk about nutritional risk, and will explore how one then assesses nutritional risk amongst patients. A 2010 UK report, which was investigating the administration of parenteral nutrition, as well as the care of patients receiving parenteral nutrition, was tabled in the UK. And what this found was, of the 877 patients that they looked at, only 19% received good practice at the time. And they found that in the other, about 80% of patients, there were various places where the clinicians could have done better. And one was, there was inadequate consideration that was given to enteral nutrition in about a third of these patients. 30% received parenteral nutrition for an inadequate indication. The need for parenteral nutrition was recognized late in 16% of these patients, and there was a delay in the administration. So even when they had seen that there was a need, there was a delay before these patients received the nutrition. And then there were various deficiencies in monitoring as well as assessment. And for me, what was quite a concern was the metabolic complications occurred in about 40% of these patients, and about half of those were avoidable. And in this era where there's litigation, they found that there was poor documentation of nutritional notes. So who would need nutritional intervention? So these would be patients that are at a high nutritional risk, and the high nutritional risk is defined as that group of hospitalized patients that are at the greatest need for nutritional therapy and would then have the greatest clinical improvement with aggressive nutritional therapy. In terms of assessing nutritional risk, there's various steps that one would take. So the first one is then you do your clinical examination of the patient. And here in the history, you want to know about unintentional weight loss. So in the last 3 months or a longer period of time, you want to know what the patient's baseline functioning was, or if they've deteriorated prior to the admission. One would try to assess the body composition, which may be difficult in obese individuals. And then you want to gauge or get an idea of the muscle mass and strength of the individual. In terms of assisting in estimating the muscle mass and body composition, imaging modalities have been used, such as CT scan, bioelectric impedance, or stable isotopes, as well as ultrasound. Of all of these, I think in our setting, what would be feasible is ultrasound. Then patients with a BMI that's less than 18.5, or who have unintentional weight loss more than 10% of what their body weight was, or more than 5% in the last 3 months, would be considered malnourished. There's various scoring systems that one would then employ to get what the nutritional risk for the patient is. Examples of these would include the subjective global assessment, the mini nutritional assessment, the malnutrition universal screening tool. I didn't cover all of the scoring systems, but I've looked at the Nutric score as well as the NRS scoring systems. The Nutric score it has been validated and is mostly designed for use in ICU patients. It looks at 6 metrics, so that would be the age, the Apache 2, the SOFA score, the number of comorbidities, and the days from hospital to ICU, and the interleukin 6. The interleukin 6 can be removed when assessing patients for, if you don't have access to the interleukin 6. And this score allows the clinician to identify patients that would then benefit the most from nutritional therapy. The score is not designed to say who should not get nutritional therapy or who should get nutritional therapy. It's designed to say, because the assumption is that all patients need nutritional therapy. And so you want to identify those ones that are at high risk, where you need to then be aggressive in your nutritional support. It should be done from the second or third day that the patient is in ICU. Because the first 2 days, one then assumes that the patient has been initiated and the feeds have been ramped up, then gradually. The shortcomings of this nutritional scoring system are that, one, it's quite complex to use, as it uses, you have to calculate the Apache 2 as well as the SOFA scoring system. And then also it doesn't look at specific nutritional parameters. So it's not looking at your weight or height or those sort of parameters. And it also predicts it correlates well with mortality. But the argument that has been made is that, it's difficult to know what leads to mortality, especially in quite sick patients that are in ICU. And so nutrition may not be the only thing that would account for a poor outcome. But perhaps one should look at functional status of patients once they've been discharged from ICU or after a certain period of time. The other scoring system that I looked at was the nutritional risk screening. This score has not been validated solely in ICU patients and is really designed for the hospitalized patient. It's convenient and simple to use, but some of the criticism that's leveled against it is that it relies on the use of anthropometric data, as well as it would rely on establishing weight loss from the patient who may not be able to give an accurate history, or perhaps the relative, but they may not be able to give an accurate history of that. With the lower weight in patients may also be related not just to lean muscle loss, but it may also be related to fluid loss. And this scoring system, though, is much more suited for ward patients. To complete your nutritional assessment, one would then also have to look at comorbid conditions. You need to look at the functioning of the gut, so whether patients will be able to absorb nutrients or not. One has to assess the risk of aspiration, and that's quite important, as it may lead to aspiration pneumonia, and may also complicate the patient's hospital stay, as well as the risk of refeeding syndrome. The use of anthropometric measures is discouraged because, one, it may be due to fluid changes, and they also mentioned that there's quite a lot of variation amongst clinicians when they measure anthropometric parameters. Then they also discourage the use of biomarkers, so that's albumin, transferrin, etc., as these are negative inflammatory markers. What seems to be in vogue is indirect calerometry, which can then be used to accurately assess nutritional requirements. However, it's not easily available in a lot of centers, and in the absence of indirect calerometry, then weight-based equations may be used. The problem with weight-based equations is that one should then use the lean mass, and they are an estimation. And so if one is using a weight-based equation, which is calculated at a rate of 25 to 30 kilocalories per kg per day that you would be giving the patient, then you should aim to give 70 to 80% of your nutritional requirement. This is because patients that have been fed at 100% seem to do worse in terms of complications related to nutrition. The other measures that one could use would be the VO2, which is really a measure of oxygen consumption, and you should be able to get that from your arterial blood gas, or the VCO2, which is a measure of carbon dioxide production, which you should be able to get from a ventilator. And then the point that was made is that not all macronutrients are equal. And so if one, for the most important micronutrient seems to be protein, and one has to ensure that patients get adequate protein requirements. And in that, one can measure the urea nitrogen to determine the protein requirements for a specific patient. This slide is just to remind you about where most of the nutrients are absorbed within the small intestine. So enteral excess, if your patient cannot eat orally, then the first preference should be a nasogastric tube. And I say that lightly, but it's not only your first preference, but it should be your best option to use. So the position should then be confirmed by chest X-ray. Other methods for confirming placement, such as air insufflation, pH, and gastric aspirates, are not considered accurate. And chest X-ray should really be repeated if there's a clinical suspicion that the tube may have been migrated. So there's no need to be repeating chest X-rays routinely to confirm placement of the nasogastric tube. There is some recent data to suggest that patients who are sicker, who may be in the ICU setting with higher Apache scores, do better with small bowel feeding, as small bowel feeding was found to have a shorter hospital stay, and those patients had less aspirates with small bowel feeding than with gastric feeding. Post-pyloric feeding should be used if the NGT is inadequate or the patient is considered a high aspiration risk. And then, so GI feeding versus, so one has to assess, would your patient benefit mostly from GI feeding or from small bowel feeding? And it's difficult to judge, but one may look at, for instance, the volume of aspirates that you receive. The disadvantage of small bowel feeding is that it requires a higher level of expertise to get your tube past the pylorus. And if you're going past the pylorus, how far would you go? So if you need to get the tube to the jejunum, then it may also be time consuming. And rather than having to wait for a particular clinician or a particular person with that skill, one should then start, let's say, with a nasogastric tube feed. And they said that for patients who will require feeding for more than a month, those patients should have a PEG that's put in place. And the considerations there with nasogastric tube is that it's related to that patients with NGTs have a higher risk of sinusitis as well as pressure ulceration. And so if the patient will require the tube for a longer period than a month, then they should have a PEG put in. I found the guidelines recommends that the peg should be placed in the antrum and to the right of the midline, close to the umbilicus, and should be kept in place with the use of T-tex. I know this isn't, what our practice has been when we're placing nasogastric tubes, and I'm quite keen to hear what you guys are doing when you're placing the pegs. Okay. In terms of initiating feeds, one should aim to initiate feeding early, and early should be, 24 to 48 hours in hospital. This is because early feeding is associated with reduced infection, reduced hospital length of stay, as well as reduced mortality. Continuous feeding is better than bolus feeding, and the benefit there is that with bolus feeding, patients tend to develop diarrhea, which they don't develop with continuous feeding, or they develop at a lower rate with continuous feeding. But in other parameters, continuous feeding was not superior to bolus feeding. There seems to be some data to suggest that bolus feeding may have benefit in that it, in terms of there's a higher absorption of feeds with bolus feeding, and then there may be a reduced rate of aspiration pneumonia. But when they compared the two groups, if those patients on continuous feed that had changes on their chest X-ray did not go on to develop overt pneumonia, so it may not be a significant advantage. If one has established that the patient is tolerating their feeds, then you should advance to the calculated goal within 72 hours. There's a population that may benefit from permissive underfeeding. So that is, they would get 70% of the goal feed. And those are patients that may be obese, patients with lung injury, or patients that may have received parenteral nutrition on the first week. And some of the benefits for permissive underfeeding is that it may help to improve insulin sensitivity, and then it may help also in terms of weight loss for the patients. And it was associated with a reduced length of stay, especially in obese individuals. They also speak about an immune modulating omega-3 fish oil, which has been shown to have some benefit in post-surgical patients and patients in the surgical ICU, but should not be routinely used in medical patients. Should one then use parenteral nutrition versus enteral nutrition? Enteral nutrition is superior to parenteral nutrition in terms of infections, complications, length of hospital stay, as well as cost. But most of this difference was shown in earlier studies where perhaps the care for the line as well as parenteral nutrition, or the care of those patients, was not as good. But now the more recent studies are showing that the gap in terms of complications is narrowing between enteral nutrition and parenteral nutrition. If there's a contraindication to enteral nutrition, then parenteral nutrition should be used as the first option. This is just a forest plot which shows what I've spoken about in terms of the benefit for infections for enteral nutrition versus parenteral nutrition. So one may divide then the benefits of early enteral nutrition into nutrient versus non-nutrient. And some of the non-nutrient benefits with regard to the GIT relate to maintenance of the gut integrity, reduced gut-lung inflammation, the enhanced motility and contractility of the GIT, and enteral nutrition also maintains the mass of GALT of the gut-associated lymphoid tissue, and it also supports the gut microbiome. Immune-related benefits are that it enhances the systemic immune function and it promotes the dominance of the anti-inflammatory T helper 2 cells, and also stimulates oral tolerance of food. And in terms of the metabolic response, you've got the incretin effect, which helps to improve insulin sensitivity and reduced hyperglycemia as compared to, let's say, a parenteral feed. And then the nutritional benefits we will explore later on in the talk. I have mentioned that not all micronutrients are the same. Protein seems to be the most important. And so one should make sure that patients receive they receive their target when it comes to protein, as this helps to maintain lean body weight. When it comes to the daily rate that's required, if the range seems to be between 1.2 grams per kg per day to 1.5 grams per kg per day. Carbohydrates, it would seem that one can get away without having carbohydrates in the feed, but it's advised that one should at least have some carbohydrate, as there are some organs in the body that depend solely on glucose, and so one should limit carbohydrates. I think the value was about 150 milligrams per day. And this really relates to the organs that would then use or limit carbohydrates to about 5 milligrams per kg per day. This relates to the organs that would use carbohydrates solely, so that's your brain, your red blood cells, etc. Higher amounts of carbohydrates seem to have a deleterious effect and affect insulin sensitivity. And in those patients that are diabetic, then it will make glycemic control difficult. Lipids should be a mixture of various types of lipids and should be given at a rate of 1.5 grams per kg per day. Then glutamine, there's some data that glutamine is beneficial, especially for patients that have burns or are post-surgery. And this is because glutamine is involved in the transport of nitrogen and is an important substrate in rapidly proliferating cells. However, the relationship of glutamine to health or to disease seems to be U-shaped. And so it's been found that if glutamine is in excess, then patients are at a higher risk of developing hepatitis, as it seems to interfere with the metabolism of ammonia. And so it's not recommended for all patients, but it's recommended for specific patients subtypes. Micronutrients, these would include iron, copper, selenium, vitamin C, and vitamin D. And they've got benefit in terms of nutrition as well as antioxidant aspects. And if they should be given according to the recommended daily allowance. And if there is a particular deficiency, for instance, vitamin D has been found, if it is deficient, then patients tend to have poorer outcome. So if there's a particular deficiency that's been measured, then that should be corrected. So in terms of monitoring these patients and establishing the adequate enteral nutrition, there should be a daily clinical examination. And then one should also determine the caloric need and calculate the caloric deficit. This is because patients who run at a consistent caloric deficit tend to have poorer outcomes. And then if for patients that are at risk of refeeding syndrome, then these patients should be fed cautiously. It's been found that nursing-driven protocols, so if nurses are given the freedom to then ramp up or increase the feeds and also monitor the tolerance of the feeds and the adequacy. Those protocols, patients on those protocols tend to do better as they tend to reach the target nutritional goal faster. The measurement of gastric residual volume is not recommended as it doesn't necessarily correlate well with, aspiration, pneumonia, or with malabsorption. And then one should aim to measure and monitor the electrolytes, and that again relates to refeeding syndrome. Complications related to feeding include diarrhea, which is common and it's usually self-limiting. And it may also, one must just watch out that it doesn't result in dehydration or electrolyte imbalances. For patients at risk, it may result in skin breakdown and wound contamination, and so it does need to be addressed. It's most commonly related to sorbitol containing medication rather than the feed, and as well as, in the appropriate setting, infections such as C. diff. Okay, the other strategy to implement, one can add a non-fermentable soluble fiber to the feed. Aspiration pneumonia, to try and reduce the risk, one should position the patient higher up. Continuous feeding continuous feeding has a lower risk than bolus feeding, and then a lower position of the feeding tube also. So if it's lower down, let's say in the gut, so that is past the pylorus, is the lower risk of aspiration pneumonia. And then if a patient does seem to have or does develop an aspiration pneumonia, then one should first initiate a prokinetic agent, and there the prokinetic agent of choice would first be erythromycin IV, and then the second one would be metoclopramide. And if that then fails, then one can look at putting, or one should look at putting the tube post the pylorus. Okay, other complications are related to, let's say, site sepsis. So one should keep the tube site clean, ensure correct positioning. Tube blockage is common, and if the tube does get blocked, to try and prevent that, one should try and make sure that the tube is flushed with saline regularly. And if it does get blocked, then one can use a non-enteric coated pancreatic enzyme tablet dissolved in bicarbonate, or you can use a carbonated drink as an alternative. If that fails and you've got access to a mechanical declogger, then you should use that before exchanging the tube. If your enteral tube dislodges and there's an established track, then the one that replaces it should be placed on the established track, and shouldn't be placed and one shouldn't open a new track for it. There may be increased drainage or leaking from the enteral tube site, and for that, one would then avoid pulling or traction on the tube, as it may enlarge the stoma, leading to excessive drainage. And in terms of fungal infections, to pick up fungal infections early, they are now using materials that break down in the presence of fungal infection, and one should endeavor to use these as you will be able to detect fungal infections early. Contraindications to enteral nutrition include critically ill patients with uncontrolled shock, uncontrolled hypoxemia, and acidosis. If your patient has an uncontrolled upper GI bleed, the gastric aspirates are more than 500 mils per 6 hours. And then if your patient has bowel ischemia or obstruction, abdominal compartment syndrome, and a high output fistula without a distal feeding access. Other than these contraindications, all other patients should be receiving enteral nutrition. Patients, so then if you can't give your patient enteral nutrition, then you should give parenteral nutrition. And patients at low nutritional risk don't require feeding in the first week in hospital. And so for that group of patients, you would not need to rush to parenteral nutrition, especially if there's a chance that they may be able to tolerate enteral nutrition. Going beyond that first week, it seems that patients do worse if they are not fed for a longer period. Peripheral parenteral nutrition should not be used as it limits the amount of nutrients that you can give. And it also it's also sclerosing to the blood vessels. Patients at high nutritional risk should be started on parenteral nutrition, and then patients, and even patients who are receiving enteral nutrition but are not meeting target should be supplemented with parenteral nutrition. It's accepted that you can do permissive underfeeding for the first 7 to 10 days, provided that your protein requirements are met. And then parenteral nutrition should be stopped when at least you're providing 60% of your nutrients through enteral nutrition. This is a topic that comes up quite often, nutritional therapy at the end of life. The guidelines were quite clear on this, saying that it's an ethical issue, but they strongly discourage the use of parenteral nutrition for this group of patients, and recommend a gastrostomy as the main method of feeding. However, the doctor should not deny the patient access to nutritional therapy. And at the end of the day, the patient's decision whether they would like to have or not have nutritional therapy should be respected. I'm now going to speak about the last part of the presentation, which is on refeeding syndrome. Refeeding syndrome was recognized during World War II when prisoners of war were released and given proper nutrition. They unexpectedly died, and it's estimated that about 14,000 prisoners died inadvertently in this way. And there's a lot of work that was done during that period, and one of the important trials which was done during World War II was the Minnesota Starvation experiment, where they took 36 healthy male volunteers and they starved them for a year to see what the effects of starvation were on the body. So refeeding syndrome is described as a syndrome which occurs in the undernourished, and you get potentially fatal fluid and electrolyte shifts, including potassium, and it seems that the more important player is phosphate. And these changes are driven by nutrition, whether that nutrition is enteral or parenteral. However, this definition has some shortcomings because it doesn't include other vitamin deficiencies and doesn't speak about the role of hormones, and doesn't allow the clinician to weigh the different features. So you don't know, is a low potassium more important than a low phosphate, for instance. This lack of a homogeneous definition translates as well into the studies, where you find that there's a large heterogeneity between studies. And so it's difficult to even do a meta-analysis because the studies are so different. The incidence depends on the population group. In one study that had about 10,000, that looked at 10,000 hospitalized patients, the incidence was thought to be about 0.43%. Some studies that look in the ICU setting find that the incidence of refeeding syndrome is as high as 34%. In a local study in South Africa that looked at 200 patients admitted to the surgical ICU, the incidence was 12.5%. It seems that the incidence of refeeding syndrome is higher in the elderly as well as the critically ill. But most of these studies rely heavily on hypophosphatemia as well as malnutrition in the definition of refeeding syndrome. The pathophysiology relates to what happens during starvation, where you have a catabolic state, essentially, with your insulin being suppressed and your glucagon and cortisol being released, leading to glycogenolysis and gluconeogenesis and protein catabolism. In the long run, this then leads to depletion of electrolytes, fats, and minerals and vitamins. When the patient is then fed, this then switches to an anabolic state, where you then have increased protein as well as glycogen synthesis, and you have increased glucose uptake. And then because now you're having an anabolic state, there's a lot of the minerals such as phosphate, magnesium, and potassium are being used in protein synthesis as well as in powering the ATP transporter. And then this then results in a deficiency in the electrolytes. So you get hypophosphatemia, hypokalemia, and hypomagnesemia. You then also have thiamine deficiency, as this vitamin is used in a lot of the chemical reactions that occur within the cell. This then results in what we call refeeding syndrome, which can manifest in various ways, including convulsions, delirium, hypotension, arrhythmias, acute myocardial infarctions, renal failure, hyperglycemia, and rhabdomyolysis. So, which patients should you be concerned that would develop refeeding syndrome? This is, patients with anorexia nervosa, chronic alcohol, patients that have chronic alcohol abuse, the elderly, patients with poorly controlled diabetes, as well as chronic malnutrition, and even patients that are obese that have had weight loss, a profound weight loss, as we've discussed before, and then those patients that may have chronic malabsorptive disorders such as Crohn's disease. And then the one that I was not expecting is the long-term users of diuretics, and they say that's on the basis of electrolyte depletion. Risk factors for refeeding syndrome may be divided into major or minor risk factors, and the major ones would be a BMI that's less than 16, unintentional weight loss greater than 15%, if someone has been starved for more than 10 days, and if at baseline you have low levels of potassium, phosphate, magnesium, that is, prior to receiving feeds. And the minor risk factors would then be considered a BMI less than 18%, unintentional weight loss that's greater than 10%, and if they haven't had nutritional intake for more than 5 days, but less than 10 days, and then the history of alcohol misuse. And then they say if you have one major risk factors and two minor risk factors, then this patient is considered to be at a high risk. The diagnosis, there's no one specific test to diagnose refeeding syndrome, although it seems that phosphate is quite important in its pathophysiology, but the diagnosis will then be based on your clinical suspicion, as well as if you then have the electrolyte disturbances with fluid shifts. When one is, so how do you then prevent refeeding syndrome? When one is refeeding, they really ought to start refeeding patients at risk. They should start at half of what would be expected as the daily caloric requirement. So they should start at 10 kilocalories per kg per day, looking to increase to full feeds over 4 days. And it may sound simple, but it's not without its complexities. There's a French cohort of 41 patients that had anorexia nervosa, where the average BMI was less than 11. And in this cohort, they had 1 death and 2 acute myocardial infarctions. 2 patients developed pancreatitis and 5 developed confusion. And so one has to be wary and cautious because you can get caught out. Thiamine should be supplemented at 200 to 300 milligrams per day. And then one should watch the electrolytes closely. And if refeeding syndrome develops, then one has to stop the nutrition, correct the electrolytes, and then try again slowly. And that's the end.
Oh, thank you very much, Sia. Thank you very much for this an important overview of nutrition. Believe me, I'm also learning, because as a doctor, it's always difficult. I've always pushed this nutrition side to the dietitian and the nursing, not being able to prescribe. Like, one has to take command, take charge and say, this is what I need for this patient. The patient has to be on 20 to 25 kilocalories per kilogram per day nutrition. Yeah, so that you take charge of that in terms of how much protein and carbohydrates and fats, now we know what to do about that. And then I just want to start with this one of refeeding, refeeding one. I'm starting it from the bottom, going backwards now. It is important to note that during starvation, if you starve for 48 hours, your body is using glucose only, all right? So you get metabolism from glucose. That's very important. That's acutely for 48 hours. After that, you start mobilizing the fat. Then you start producing free fatty acids, all right? And then later, after that, maybe after a week or so, then you start mobilizing your protein. Now that's when now you lose muscle bulk. The relevance of this is this: if you feed somebody, then they will very quickly revert to glucose metabolism. Now the body will catch that glucose again very quickly. Then they'll go through the glycolysis pathway. Then that's where things go wrong in terms of your phosphate. The phosphate will be mobilized because you need to form ATPs from ADP. And then the cells also take up the phosphate, so you go to severe hypophosphatemia, basically. So that's the reason why I'm trying to explain that glucose, the body will go first for glucose. And then when that is happening as well, the insulin will respond, and then we'll do stuff to the potassium as well. So that's why it's important to know the phosphate and the potassium, and they're very dangerous when they are lower side in terms of your membrane stability, you know that. So because I've said your requirement is about 20 to 25 kilocalories per kilogram, then it's understandable if you prescribe for someone if you want to avoid refeeding. If you just say half, which means 10 kilocalories, then those figures will come automatically as half, basically. Then you can avoid refeeding. Okay, that's the refeeding syndrome, which I think that one is quite a serious thing, but you can anticipate those things for those guys who have been fasting for too long. Now, when I'm going to the nutrition now, as a doctor, like we're going to prescribe again in terms of nutrition now. I think we have covered everything in terms of it's oral, better than enteral, better than total parenteral, basically that in that order. And I think you've also alluded to I think where you should try to avoid or delay enteral feeding. You delay, not necessarily avoid, because some of the things can be treatable. For example, if there's aspiration of the stomach contents more than 500, that's where you can still attempt things like metoclopramide or your erythromycin, basically just to stimulate so that things can go through. And then in high output fistulas as well, some people recommend that if the fistula is draining too much, there's something called chyme reperfusion, where they can take that chyme which is coming from the back and reperfuse it again distally. There's a machine available for that. I've seen something like that from Australian authors. And then there's a specific, in terms of estimating the caloric intake, is difficult in patients who are obese. In obesity, when the BMI gets above 30, 35, it can get difficult. So then you are required to know things like ideal body weight, apart from the BMI or normal weight. And then you have to know concepts like adjusted body weight. They've got some formula there which they think can be useful, especially if you do not have these machines which can do for you the indirect caloric measurements for obese patients especially. So I think that, yeah, having said that, I think you covered everything very well. It's a wide subject, and I don't have anything terribly important except, I mean, you have said everything, which I think we are getting empowered in terms of knowing how to prescribe and when. Oh, the other thing is, it is recommended, there's a concept of overfeeding. You can overfeed patients, then there might be a poorer outcome in the end. So it's recommended, actually in the first 48 hours, maybe, you should strive for about 70%, maybe 70% of the total caloric intake, which would be normal for patients for the first 48 hours. Then thereafter, you can start to push up to the normal requirements, basically. And then obviously, if you're failing to maintain 60% of this weight of the requirement, 60% by your enteral, that's where you can consider again TPN and vice versa when we come back, basically. Yeah, so I do not know if there's anything I have to, because we are short of time already, but I think you've covered everything. The glutamine, I think, is important for the health of the enterocytes, so that you can avoid the leaky guts and those things. The glutamate business, if you don't have enough adequate muscle, you won't be able to, your glutamate does not bind ammonia to get glutamine. So it's dependent on your basal bulk. And that thing actually is also important in your liver failure patients. Liver failure patients who lose muscle is bad. They keep on going to encephalopathy because they don't have muscle enough to convert the glutamate to glutamate or vice versa, basically. But glutamine is a first neurotransmitter as well. Yeah, I do not know if there's anything I should say. Obviously, if we give glucose, we have to give thiamine to everybody. It's important for that, from glycolysis across to the Krebs cycle or citric acid cycle. Yeah, not unless there are any other questions which are been. Let me just check the chat box here. I don't see anything. Sorry, I might have missed. Okay, let me just check from the beginning. Link. Feedback, all right. Please use link. Sorry, I must. How would we define prolonged starvation and its relevance? I'm not sure if you have anything on that, Sia. I think the relevance is that if you want to correct that, you have to watch out for refeeding syndrome. In terms of prolonged, I'm not sure. Is there anything like that? I don't know.
They say that if patients have been starved for more than 10 days, that puts them at a high risk of developing refeeding syndrome, and it's a one of your major risks, one of your major points in terms of your refeeding syndrome risk. And then if they've been starved for 5 to 10 days, then it's considered a minor risk factor, for developing refeeding syndrome.
Okay, thanks. I hope that answers the question. I hope that answers the question. So I do not want to repeat myself, reiterate. We have to anticipate. If somebody's going to spend more than 48 hours without nutrition, you have to work hard to make sure that you assess them properly so they can decide on enteral or vis-a-vis later TPN. And then, yeah, basically that's what I can say now.
And then Dr. Ramonati, in terms of placement of the pegs, I mean, is it
yes.
also your practice that you place them in the enteral?
The percutaneous enteral, gastrostomy tube, is put on the anterior part of the stomach, but towards the antrum. I mean, it's towards the antrum, but I'm not sure about the midline, but usually on the lateral side, towards the left, when I put it here. I'm not sure if there are any physiological reasons why it should be on the lateral side of the midline, but it should be in the antrum on the anterior side of the stomach. Anterior, it's anterior, yeah, abdominal wall.
Yeah.
Yes, because that's where you'll be working, but on the antrum, not the fundus. But like I've said, I'm not sure about the physiological reasons. Maybe Mesh can tell us about the physiological reasons now. I'm not sure. Mesh, I know it's late, but
it just yeah, I mean, I agree with you. We place it towards the antrum and at the place where you get the best transillumination.
Yeah.
You
so,
do your, and then you get the best transillumination in the region of the antrum, and that's where we place it. And it might vary slightly with each patient depending on their body and their capacity, etc. But that's generally where we go.
Good. And then
Have
this
you
thing of
put any years here yet?
No, I haven't put one myself. But when I saw the guideline saying, at the antrum as close to the umbilicus or to the right of the umbilicus, I think ours tend to be maybe higher up around the epigastrium.
Ours also tend to be on the right side because of the way the patient is lying, generally, mostly.
Yes.
We don't specifically aim for that, but I think because of where we poke and we transilluminate, that's where they tend to end up.
Okay.
Good. Yeah, I'm not sure if there's anything else. I think, yeah, like I'm saying, this post-duodenal thing, if people are worried about aspiration, I think this is our patients, neurology patients mostly. That's where you'll be worried about aspiration or that, ventilation, whatever. That's where you can be thinking of these jejunal tubes, but you need some skill for that one if you want to consider post-duodenal insertion, post-antral or insertion of the tubes there. I think that'll be you need a surgeon to help with that. But there are indications. Well, yeah. And then what is important for everybody, please, I recommend, I strongly recommend this article. It's the guidelines from, what did I do now? It's an ESPEN, stands for European Society for Clinical Nutrition and Metabolism. ESPEN guideline on clinical nutrition in the intensive care unit. It's quite long, but it's simple. I found easy to understand and to read. It's it's found in the Journal of Clinical Nutrition. But I think if you just Google that, you'll get it from Google Scholar or something. ESPEN guideline on clinical nutrition in the intensive care unit. Please, I wish you could get that for reference. All right. With that, then I need to thank you, Sia. Thank you very much, and thank you very much again, and to the ECO University of Michigan, New Mexico, right? Sorry, and the ECO India team for the support. And then we've been encouraged to do some feedback on the online there. There was a link that was given for feedback. And the recordings will be available on the Gastro Foundation website. And again, we have to thank the Gastro Foundation for making these things possible, basically. Our next presentation will be on the 18th of July. No, am I correct? 18th of July, yeah. That will be Dr. Lawrence Kwape and with Prof. Ali, Reed Ali. I think they'll be talking about food allergies and intolerance. Food allergies and or intolerance. 18th of July. 18th of July, please. Yeah. 18th of July.
You are correct, and there's going to be a couple of weeks break over the school holidays. So you are correct. There's a 3-week break before the next one.
Okay, thank you very much, everybody, and again, well done, Sia. Thank you very much, and good night, everyone.
Thank you, everybody. That was thoroughly enjoyable. Thanks.
Bye.
Bye-bye.
Thank you.